Well, good morning, everyone. My name is Jessica Moshe. I am a pharmacist and the Region D director for the board. This is the last concurrent session of the morning, and lunch will be provided afterwards. Those attending school-sponsored lunches are encouraged to use the app to find the luncheon location. Don't forget about a cardiometabolic crossroad, considerations in obesity care presented by Novo Nordisk during lunch in 103 ABCD. Check out the app for more details, and don't forget that we have more programming after lunch, along with the 2025-26 PSW President's Address. I'd like to officially welcome and thank you for being here. This session is designed to engage pharmacy students, pharmacy technicians, and pharmacists in examining the evolving changes and opportunities facing health system pharmacy today. Throughout this session, you'll discuss the strategic and operational pressures health system pharmacy leaders are navigating in today's political and financial climate. You'll explore alternate payment models designed to address the rising costs of the ultra-high cost drugs, consider how health systems can reframe their focus from solely treating disease to promoting whole person health. And finally, we'll review emerging workforce trends and the growing concern around a potential pharmacist shortage. So please join me in welcoming Carmen Gust, a passionate pharmacy leader with a strong background in clinical practice, operations, and strategic development. Carmen began her pharmacy journey as a technician at UW Health and has since completed 2 residencies, including a PGY2 in Health System Pharmacy Administration and Leadership. She currently serves as pharmacy manager at Ascension St. Elizabeth Hospital in Appleton, Wisconsin, where she leads initiatives to advance patient care and team development. Carmen is board certified in pharmacotherapy, a graduate of the ASHP Pharmacy Leadership Academy, and a 340B Apexis certified expert. She's also an active preceptor and national leader, serving as chair of ASHP's Section Advisory Group on Leadership Development and Succession Planning. So please join me in welcoming Carmen.
All right, thank you so much. Really appreciate that introduction. Let me get situated here real quick. All right, lower the mic. That's always my MO. So thank you so much for joining me today. Last session before lunch, so we'll get you fed soon here. The ASHP pharmacy forecast, you'll learn a little bit about it if you're not too familiar with it, but comes out every year. And I happen to, as Jessica mentioned, I'm going into my chair year of what was formerly known as the New and Emerging Leaders SAG for ASHP, now going to be Leadership Development and Succession Planning is going to be the new name. And we are actually the section in charge of developing these slides. So I like to come here the last couple of years and make sure we kind of get this information out to all of you. So. All right. So I have no relevant financial relationships, and none of the planners for this activity have anything to disclose with any ineligible companies. After completing this session, you should be able to discuss the strategic challenges associated with health system pharmacy in our current political and financial landscape, identify alternate payment models to tackle paying for ultra-high cost drugs, describe how health systems can shift from treating and curing diseases to promoting overall health, and list the trends that are causing concern from impending pharmacist shortage. So, the pharmacy forecast has a long tradition of providing insightful perspectives on factors that influence patient care, the health of populations, health systems, and the pharmacy profession. As the philanthropic arm of ASHP, the foundation supports the pharmacy workforce by funding research and education to improve health outcomes through optimal medication use and to demonstrate pharmacy's impact. Through the pharmacy forecast, ASHP and the foundation assist pharmacy leaders as they navigate through developments in key areas of opportunity or challenge over the next 5 years. While this report is primarily designed to help health system pharmacists and pharmacy leaders help inform their strategic planning efforts, it may be useful to any reader interested in future developments in health systems and pharmacy practice. The new perspectives and emerging trends identified in the 2025 pharmacy forecast should prompt action by pharmacists and health system leaders. The report's format is intended to guide action with specific strategic recommendations provided at the conclusion of each chapter. The report is intended to be a proactive stimulant for the thinking, discussion, and the planning that must take place in every health system. Leaders must be informed of potential external developments to position the organizations to care for patients, enhance population and health, and improve medication outcomes. So the kind of format and the methodology used in the forecast is there is an appointed forecast panel and they complete a questionnaire. The survey asks the likelihood of certain trends occurring over the next 5 years, and they can range from very likely, somewhat unlikely, to very unlikely. And then there is also experts recruited to write a brief chapter for each domain across the country. And then each chapter presents the survey results, the author's assessment of the predictions, and then also gives strategic recommendations based on this information. So the representation for this year's forecast was 52% of the panelists come from hospitals with 500 beds or more, and 21% came from hospitals of less than 500 beds. The geographic spread was the Midwest was about 35%, the South 30%, out West 18%, and the East 17%. So the 6 themes being represented this year in the forecast were strategic challenges in health system pharmacy, managing ultra high cost drugs, addressing the gap in primary care, whole person health in US healthcare, navigating generative AI opportunity and risk, stabilizing the pharmacy workforce. The numbers highlighted in yellow will be the ones that we'll cover today just for time's sake. So that's why those are highlighted. So that moves us into our first theme, strategic challenges in health system pharmacy. So due to the expansion of pharmacy services over the last 5 years, the complexity of enterprises continues to increase and creates strategic challenges for all of us. Um, the challenges include market pressure on health systems with infusion services and other things that have kind of come up in the last year. Actually, since this has been written, a lot more. I think we're getting pressure on those margins at every institution. There are hospital and infusion care at home pressures and challenges, and then Medicaid coverage. So payers increasingly forcing reimbursement of outpatient infusions through the pharmacy benefit of insurance policy is kind of adding a lot more pressure to every system. So most health systems, around 59%, have reported through these panelists that they are not prepared for this change, and it will be a significant financial burden and vulnerability for them. So some prominent examples of shifting reimbursement is with we've talked about this a lot in the last few years, is with the different various bagging practices. So from white bagging, brown bagging, clear bagging, you'll hear that a lot. Um, all of these bagging tactics decrease costs for insurers to differing extents while increasing the out-of-pocket costs for patients and creating administrative complexity, waste, and also proposing patient safety risks for healthcare providers. Further, brown bagging, as you probably talked about in your institution, has chain of custody and handling risks that are introduced when the patient is required to handle these medications. So this is kind of my first kind of discussion question, if you will. So feel free to either step up to the mic or I can come down and hand somebody a mic. I'll be asking questions kind of as we go through this just to kind of generate some conversation, really wanting to know if anybody is doing any of these certain things at their institutions. So maybe just by a raise of hands right now, how many at your institutions have instituted white or brown bagging restrictions? Okay. I think a lot of people are kind of implementing those, just especially with the brown bagging, trying to get around some of the white bagging, and probably incentivizing if you have the capability, clear bagging in your institution. Has anybody kind of implemented new clear bagging or made a bigger push for clear bagging at your institution? Not quite yet. Okay. Does everybody know all the differences between the white and brown and clear bagging? If not, I maybe should go through that. No? Okay, I can go through that. So white bagging is when the specialty pharmacy ships a medication to the provider, and then we, as a health system, will administer the medication. Brown bagging is when the specialty pharmacy actually sends it to the patient. So that's where this kind of chain of custody comes into question. Um, it can't be for certain that they're storing it or handling the medication correctly before it gets to you. So there's like a safety element risk there. So a lot of places have kind of eliminated brown bagging for that reason. Um, and then some places have also implemented eliminating white bagging because we're using all of our services and labor to compound these medications, but then we're not getting any of the kind of reimbursement back from those medications. And then clear bagging is when you have your own specialty pharmacy within your health system, and you can kind of use that vertical integration to really maximize reimbursement. You're buying the drug, you're compounding the drug, you're administering it to the patient. So in December 2023, the U.S. House passed H.R. 5378, the Lower Cost, More Transparency Act, which includes a provision requiring Medicare to implement site-neutral payments. This means Medicare Part B will pay healthcare providers the same rate regardless of where the medication is administered, whether it's outpatient or in a physician office. While not yet law, 75% of panelists indicated that the likelihood that the passage of site-neutral policy reform will negatively affect healthcare systems revenue. Has anyone in this audience begun mitigation strategies for site-neutral payment policies? I think it's just because it's kind of, we've talked about it a little bit, but we haven't like implemented anything from a mitigation standpoint. So it'll be kind of interesting to see where that goes as that kind of comes into law. All right, so transitioning some acute care services to the home setting offer potential cost savings opportunity and is also more convenient for patients. This allows potential for the health system to further extend their integrated services and retain market share. How many of your institutions have made kind of a push in maybe the last few years to either implement hospital or acute care at home at your institutions? Excellent. I don't know if any of you are brave enough or has any great success stories or barriers that you would want to talk about with that. I know it's kind of intimidating to come up to the mic, but all right. So, from this theme, there are the strategic recommendations. So, we'll go through those. Health system leaders should work with policymakers to restrict bagging practices by emphasizing the risks to patient safety, negative financial effects to patients, and the administrative burden this practice places on health systems. Pharmacy leaders should collaborate with health system finance experts to model the budget impact and measure financial risks associated with the site neutral payment policies. Health system leaders should work to ensure that policymakers understand the advanced standards of care required to ensure safety and quality when administering medications in health system based facilities, which justifies the differential in payment. Pharmacy leaders should identify treatments suitable for safe and effective administration in the home and collaborate with finance experts to model the financial opportunity and develop the resources required to ensure the success of these home-based treatments. Pharmacy and health system leaders should coordinate with physicians, community clinics, and affiliated pharmacists on strategies for disease prevention and disease management programs that include and support the education of Medicaid patients on the available services as part of their transitions of care. Oh, all right, so that brings us to our first learning assessment. Of the options below, which was not a strategic challenge that was discussed? A, hospital and infusion care at home. B, Medicaid coverage of undocumented individual. C, natural disasters are decreasing in frequency. D, market pressures on health systems with infusion services. All right, good job. You're still with me here. That's good. All right. So that brings us to theme two, managing ultra high cost drugs. I know this was also discussed, I believe, in last year's forecast because it's continuing to be a major topic of discussion, a major financial concern for most systems. So, ultra high cost drugs or UHCDs, such as gene and cell therapies, you'll probably hear me refer to it as cell gene therapies. You'll hear that a lot. Typically target orphan and rare diseases and can cost millions of dollars per patient for a one-time treatment. The FDA has approved, since these slides have been made, it's actually up to 45 different therapies. So that's how much this has increased since these were made, which is pretty remarkable. I just checked last night to fact check myself. But um, so as you can see, this isn't stopping anytime soon, and it's more and more, and we really need to kind of figure out how we're going to be able to facilitate and pay for all of these medications. So they range from rare diseases and to chronic illnesses, including cancer, blood disorders, leukodystrophies, muscular dystrophies, and retinal disease. Oh, sorry, I didn't. All right. So, paying for these drugs, around 0.8% of total pharmaceutical spending in the US is spent on cell gene therapy. Approximately half of the spending on gene therapies is expected to take place outside of Medicare due to treatments targeting a younger patient population. Therapies in the Medicaid program may lead to increased tax cuts or cuts in benefits. And then commercial payers may restrict access or increase payments based on some of these high dollar therapies. So, have any of your organizations worked with revenue cycle teams to assess the cost of care for these or discuss the financial impact they may have? Excellent. Um, has your institution, are you handling approval of these drugs in a different like governance than you do like your typical P&T? Can I ask? Yes. Okay. I know that was a big discussion about a year ago with other national leaders is how do we address this? Because it's different than your typical P&T drug just being bought to formulary. Like some of these are upwards of over $3.5 million per treatment. So lots of other things that need to be considered. All right. Does anybody want to add anything or any stories about that? No? Okay. All right. So while the clinical benefit of treatment may last a lifetime, the high expense occurs at a single point in time. Single beneficiaries needing treatment could bankrupt a small insurance plan, especially some of these self funded employer plans. And then, due to the limited clinical trial data, there is uncertainty about the actual expected clinical outcome for these treatments. So there's alternative or alternate payment models being considered. So additional per member fees to ensure access to these drugs, private insurers contributing funds to pay for cell gene therapies, and then additional benefits to Medicare plans that would make cell gene therapies accessible to all patients nationwide. So the other aspect of this is access, right? And the logistics of it. So not all centers will have the capabilities to provide these drugs, whether it's a lack of proper equipment, monitoring, expertise, and then like the supporting service lines that they may require. Additionally, manufacturers may elect to only work with a limited number of sites. Um, so the low patient census of these treatments per year make it unlikely to generate a return on investment. Manufacturers may also stipulate pharmacist involvement as part of the risk and evaluation and mitigation strategy or REMS requirements. And pharmacy departments must have staff with skills to prepare complex therapies and manage their safe handling. So, have any of your institutions, if you are considering any of these drugs, has anybody actually instituted additional requirements and learning from your pharmacy team or been any discussion with that at this point in time? It may still be too early for that, but okay. So that's something that we'll have to consider as I think there's some students in here as you kind of move into the workforce is understanding you'll have to gain new skills and knowing how to handle some of these medications. So then comes the kind of the ethical side of this. Health systems cannot afford to subsidize access to all of these medications. And then health systems also have limited control over who gets the drug because it's usually a payer decision. So that kind of makes the outcome-based payment model may provide greater access to more patients and makes it more desirable from a health system aspect. Like some of them are kind of set up where you'll get reimbursed X amount if you meet these certain endpoints. So that's kind of how some of them are set up. So it's kind of at least like guaranteeing some kind of clinical benefit before you have to pay for it, or you get how the reimbursement works, et cetera. So um, I don't know. It doesn't sound like anybody's really taken too many measures into implementing these, so I won't probably ask these questions, but I think we'll have to consider when you're negotiating these contracts of these medications, using these as different like outcome-based models to ensure that you're not, ending up so much upside down on some of these medication therapies. All right, so that brings us to the strategic recommendations for this theme. Health systems should determine if they have the financial resources, established service lines, and clinical expertise to provide these drugs. Pharmacy leaders should establish relationships with their state Medicaid program to determine if their state plans to participate in the cell and gene therapy access model and how their state plans to provide these ultra high cost medications. Health systems should partner with manufacturers to become a preferred site of ultra high cost drugs. And particularly if they are already being involved in the clinical trials at their system, health systems also should proactively negotiate with manufacturers to ensure ongoing access for the site if the product becomes commercially available. So if you're agreeing to do the study drug there, work that into the negotiation of making sure that you have access to it when it becomes commercially available. Health system pharmacists must ensure that they have a seat at the table to work with organizational revenue cycle. I think this is important in many aspects of pharmacy, but definitely particularly in this case, and contracting teams to determine the potential full cost of an episode of care for an ultra high cost drug. Pharmacy leaders should be prepared to work with C-suite administrators to prepare for inevitable financial variances that may occur due to significant purchases and the then lagging reimbursements. Financial leaders across health systems should develop training programs to equip health system pharmacists and technicians with the knowledge and skills to manage and administer ultra high cost drugs efficiently and safely. All right, next learning assessment. True or false? Health systems should determine if they have financial resources, established service lines, and clinical expertise to provide any ultra high cost drugs. All right, true. All right, moving on to this is the fourth theme of the forecast, but our third theme here, whole person health in the U.S. So traditionally, health systems have focused on treating and curing diseases rather than promoting overall health. Whole person health places emphasis on the following factors for the individual: biological, behavioral, societal, and environmental. Aligns with the individual, these this ethos aligns with the individual's life's mission, aspirations, and purpose. It shifts from a reactive point of care to one that prioritizes disease prevention, health, environment, and well-being. So these measures of effectiveness for whole person health should be integrated into the entire healthcare delivery. So fee for service incentivizes treatment of illness and has limited accountability for spending and quality. Centers for Medicare and Medicaid Services launched a new voluntary primary care model, Making Care Primary, that provides prospective payment to improve value of care, practice transformation, and care coordination. The electronic health record will integrate whole person health goals for each specific patient, and it should ensure all care providers have access to the same patient information. The interoperability will be vital and span the medical settings to community and social care settings. So, with that said, have any of your institutions integrated a whole person focus into your electronic health record? And if so, how? No one yet? Okay. Might be able to be coming. Pharmacists will integrate whole person health into medication management and medication use process and a collective approach with other healthcare professions. Medication regimen will be aligned with patients' goals, preferences, and health plan. An increasing number of primary care practices have clinicians working as part of interprofessional teams, including behavioral health specialists, community health workers, health coaches, and pharmacists. Pharmacy can provide screening and social determinants of health and coaching to improve medication adherence. Have you seen any of your practice kind of implement any of these? Excellent. I know when I was at Theta Care, they had some teams that were doing some of this kind of work, and pharmacy was getting involved in kind of going into the home of certain high risk patients and assessing care and things like that. So maybe some other institutions are doing things similar. Great. So, the strategic recommendations for this theme are that health system leaders and pharmacists within healthcare systems should develop methods to measure the impact of integrating whole person health on health outcomes and patient experiences. Health system leaders must advocate for payment models of both public and private to address whole person health. These models should include the entire interprofessional team, recognize the pharmacist's role, and support the full scope of whole person healthcare services. Health system leaders should strengthen their informatics infrastructure and improve interoperability needed to partner with community programs, social care, and public health systems. Schools of pharmacy should build whole person health concepts, including patient experience, into the curricula and training, and determine the best methods to ensure that learners meet competencies. Pharmacists and health system pharmacies should develop tools to optimize inclusion of whole person health into the daily practice of medication management and the medication use process, including identifying best practices for pharmacists and pharmacy technicians, workflow redesign, and specific whole person health policies relevant to medication access. So I see some students in here, some people representing academia. Has there been more of an initiative to kind of talk and teach to the whole person, would you say, over the last few years, or has that just always been maybe what we do? I feel like it was part of my curricula when I was in pharmacy school. Okay, excellent. All right, that brings us to our third learning assessment. Select all that apply. Ways that health systems can ways that health systems can incorporate whole person health into the care of their patients include which of the following? A, aligning the medication regimen with the patient's goals, preferences, and health plan. Advocating for payment models that address whole person health. Focusing on how much a medication costs for the health system. Developing tools to optimize inclusion of whole person health into the daily practice of medication management. All right, I think I heard the answer. A, B, and D. Good job. All right, so that brings us to theme 6 of the forecast and our fourth theme that we will touch on today, which is stabilizing the pharmacy workforce. I know we've talked about this a lot, I feel like, in the last few years, but it's not going away. And I think it's continuing to burden all of us. A major concern, probably every week, month, with rotation of staff and trying to keep up with, properly staffing your pharmacies. So, according to the American Association of Colleges of Pharmacy, there has been a greater than 30% decline in pharmacy school enrollment. Over the past 5 years, there has been a 500% increase in unfilled pharmacy residency positions. The U.S. Bureau of Labor Statistics estimates that pharmacist jobs will grow at an average of 3% over the next decade. Continued innovation will require highly trained pharmacists to manage new therapies, including cell gene therapies, as we already discussed. So, pharmacy school enrollment continues declining, resulting in fewer students pursuing residency training. Panelists generally do not believe that there will be a significant increase in pharmacy student enrollment by 2029. So most of the panelists are predicting this trend is going to continue over the next few years. 68% of respondents believe that the profession is highly unprepared for the scenario in which 20% of residency positions will go unfilled. Non-traditional residency programs or more robust competency-based training programs could mitigate the knowledge and skill gap while providing growth and retention incentives for the existing workforce. So how many of you, especially if there's students in here that maybe aren't considering residency, do you think if there was more of a robust competency-based training program, would that possibly make you more interested in going into residency? I know I've heard a lot of, I got to pay off these loans. I don't know if I can do residency. I don't think anybody argues that it's not beneficial for sure for your, clinical knowledge, but maybe just a raise of hands if you think maybe having more robust residency training programs or something similar could make a difference. Okay, great. Thank you. All right. So the expansion of the pharmacist's scope of practice while the pharmacist pipeline shrinks presents challenges for providing advanced services. Boards of pharmacy can mitigate the pharmacist shortage by expanding the pharmacy technician's scope of practice. Defining patient care activities that can be independently performed by pharmacy technicians would allow pharmacists to focus their time on higher level patient care activities. So I'm sure most places have done this. I know we have. Does anybody want to maybe talk about a success story in maybe a unique way that they've expanded technician roles and how that's helped kind of like expand services or reduce pharmacist burden? I think most of us probably can raise our hand that we have made some of these positions or added more in our health systems. Yes? Great. All right. So over half of the panelists believe that boards of pharmacy will reduce barriers to licensure by simplifying the application process for foreign pharmacy graduates. Reducing the barriers to licensure provides more pharmacists into the pipeline and helps reduce the burden of fewer pharmacy students. Health systems continue to expand their reach through expansion and association, sometimes crossing state lines. Simplifying reciprocity between states will become more important as this expansion continues, and pharmacists are expected to practice care in multiple states. The reciprocity process for physicians who practice in multiple states has become much simpler than for pharmacists due to the Interstate Medical Licensure Compact. Similar compacts should be adopted for our other healthcare professions. I think we can all agree to that. A different law exam for every state. I think I have 3 right now. I've taken 4. I've moved a lot, so it's kind of ridiculous and burdensome. I do, I understand the importance of knowing the laws, but if we can make that kind of easier for our other healthcare professionals, why not for pharmacists? All right, there are more than, well, that's not correct. There's more than 45 at this point, 45 innovative new agents classified as cell gene therapies in the Food and Drug Administration pipeline that were kind of coming to fruition in the next year or so. 10 of these agents, probably more than that now, are expected to cost greater than $1 million per treatment course. So kind of wrap your mind around that. That's wild, right? 83% of panelists indicated that it was very or somewhat likely that 75% of health systems will require pharmacists who manage cell gene therapies to receive advanced training. Only 13% of panelists believe that health systems are prepared to manage these ultra high cost cell gene therapies. So that brings us to the strategic recommendations for this last theme. Health system pharmacists and ASHP should introduce approaches to increase awareness of health system pharmacy practice among current student pharmacists and potential enrollees to colleges and schools of pharmacy. Pharmacy leaders should consider incorporating into their strategic plans a 20% decrease in PGY1 residency graduates in the next 5 years. Plans should contemplate the potential impact on practice models, advanced roles, and the delivery of patient care. Health system pharmacy leaders and pharmacy organizations should advocate for the adoption and expansion of interstate licensure compacts for pharmacists to support greater patient access to pharmacy services. Health system pharmacy leaders and pharmacy organizations should support transformation of the current patchwork regulatory practice framework of individual states to incorporate the ideals of a standard of care model. Health systems must prepare the current and future workforce and adapt existing care models to ensure that the clinical, operational, financial, and longitudinal care needs of patients are met when they receive innovation and complex cell gene therapies. So that brings us to our last learning assessment. Select all that apply. Which trends are causing concern for an impending pharmacist shortage? A decline in pharmacy school enrollment, a decline in unfilled pharmacy residency positions, growth of pharmacist jobs at an average of 3% over the next decade, a decrease in innovation, and a decreased need for highly trained pharmacists to manage new therapies. A and C. All right, so that brings us to our citation and some special acknowledgements. For the Forecast Advisory Committee, special acknowledgement to them, the chapter authors for the forecast, and then the forecast panelists who responded to the survey. And then this is the work group that I help chair. These are the individuals that actually help oops, put together the slides. So special shout out to them for putting these together. Since we have some extra time, and I didn't put it on here, but I'm kind of interested for my own personal interest to know. One of the themes, if we go back to beginning, was navigating generative AI opportunity and risk. So I'm curious to know if anybody's actually implemented any AI in their health system and what is it? What are they doing with it? Just out of pure curiosity, because I feel like this is going to be the wave of the future. Has there been discussion about it? Oh, yes. Okay, so just to put it on the mic here, it sounds like you're seeing kind of providers and other healthcare professionals use AI, maybe not like in a formal sense that it was rolled out by their health system, but they are definitely using it. I mean, I can say I've used it in my own work for sure. I think it can be helpful. I think you have to be careful, like you're talking about. I think it may also bring about potentially, are we going to have these new ethical committees talking about these things and what does that mean next? And I know that's a lot of the big kind of talk from national leaders. And I think it's something we could take advantage of, but we have to make sure how we manage it carefully. But I definitely think I'm not that I'm predicting, you should listen to me or bet on me, but I would be very surprised AI isn't going to be playing a bigger role as we kind of go through things. I think it helps throughput. It'll help things kind of go make decisions faster, maybe get you to the right, um, you know, list of potential diagnoses or something like that. It'll narrow the list faster potentially for you and then kind of work through those things. Maybe that's a certain example, but yes, what were you going to say? I love that comment. So I'll just kind of review what you said. We need to make sure that we're getting ahead of this because if we're putting patient data, HIPAA things to these programs, even if you're kind of disguising it, at some point your company's going to get worried about cybersecurity or a HIPAA violation, and they're going to shut it down, and then we're not going to be able to use it at all. So we need to make sure that we're getting ahead of it and educating everyone on how to use it and how to safely use it. Excellent. So I will try to recap all of that. I think the first thing you talked about was you're utilizing it to help kind of be able to summarize progress notes and implement it into the chart and things like that. The next portion, which I have heard a lot about, I think a lot of places are using this with like PAs and things like that, writing the letter so you can get a drug through faster. You don't have to have the administrative burden of somebody writing the same letter 16 different times. AI is doing it for you and sending it right off so that you can get approvals faster and things like that. And then lastly was kind of cross-referencing guidelines and with a patient and what medications they're on and things, and just making sure there's nothing that was missed of other therapies that they could be using. Excellent. I think that all sounds really, to me, I think that's exciting. Like, we're making care better. There's things you're not missing. I don't think it takes us out of the picture because, like you said, we still need to make sure you're looking at the patient, right? Um, and um, you still need to, like, that's why there's clinicians, there's an art to it. You still have to look at the patient and see what's wrong with them. And it's not just all black and white and X's and O's. Um, so I think it only uh, helps us be better clinicians. And you learn things from it too, I think. But like you said, it's taking the information we're putting into it. So we better make sure that we're also making sure that information is correct. We need to be careful with it as we kind of implement these things. Institutions may want to create their own internal AI chat things that can be used so that it's not going to any kind of external force. And who knows what's happening with that information, right? So anything that goes external can be something that could be bought or sold of any way, shape, or form, right? So thank you. Yeah, I think I really wanted to talk about that kind of like after I had already submitted my slides. I was like, I should have put the AI in here, but we had a really great discussion about it regardless. So, all right, let's get to what y'all are waiting for. Sorry. The code. Oh, did anybody have any questions though? Yeah, go ahead. Okay. So the conversation that's being had in the audience here is a big concern about the decline in 20% of the PGY1 going open um, in the next few years. And why do we think that's happening? And B, what are we doing about it? I guess I can start the conversation. I think what I've heard from a lot of people, I'm pro residency. I did 2 years of residency. I went to pharmacy school later in life, so it probably made less sense for me as far as ROI to be doing it, but I did it anyway. But I think a lot of people with kind of inflation, the cost of pharmacy school, a lot of financial burden. Um, Most people been told is they're not sure they can afford not to try to get a job right away and making like their full salary as a pharmacist. I've heard that probably the most. Um, and then B, that they don't necessarily think they need it everywhere in practice. Now, I sure you don't need anything, but there's, a residency I think is invaluable. And like you're saying, we're going to have these specialized therapies, these different kind of tracks are going to take more expertise and things from pharmacy. We do need that extra training. But I would like to engage the audience to see, especially we have some students in here, what are some other things that maybe, your hesitation is for going into residency? Yes, please. Yeah, and I definitely won't speak on behalf of ASHP. Might get in big trouble there, right? But I can't. I'm sure it's been discussed, but I don't disagree. What are we doing to incentivize people to do these residencies? Has um, the stipends or salaries you're getting with residency, has it risen appropriately over the time based on, you know, um, inflation and things like that, and market adjustments in different areas, et cetera. Yeah, I don't disagree. I think it's definitely burdensome. It's work, right? It's hard work. I don't think residency is a breeze. You do have to put aspects of your social life on hold. Um, some people can manage that really well, and some people can't. I was all in, you know, residency. My husband even lived in a different state during most of it. So it was just work. But so you definitely have to be committed to it. But as you kind of spoke to, how are we rewarding people for giving that up? Not even just from like a financial aspect. What other things can come from that? Is there a way we can relieve student loan or something like that from that potentially? Yeah, no, I think that's an excellent point. I think as a profession, we definitely can do a better job of the messaging of why it's important to do a residency. And I think, if you're looking for immediate, reward, I do think there's things that come from like the amount of critical thinking that you have to do in residency is much different over time. I'm not saying that you can't do it if you came straight out, so I don't want people to get offended that way. But I think there's a different level of critical thinking. There's a different level of time management. There's a different level of managing a lot of things at once. You're seeing the whole system of healthcare in a much shorter snapshot, which just makes you a better clinician, a better professional. better for your patients and your peers. So I don't disagree. I think maybe we need to do that. I know there's some campaigning through ASHP, I believe. I don't want to get this wrong. I think it's like We're Your Pharmacist. Is that what it's called? That's so maybe we need to kind of work on that messaging within that is talking about residency and why it's so important. So, and I can take this back to ASHP too. I do talk to some of the leaders there. So excellent. Thank you. I really appreciate that. Anything else anybody wants to discuss? This has been excellent. Yes, I think that makes sense. And I think it comes back to how are we rewarding people that have gone through residency? I think maybe I got paid a little bit more at some point for having like my board certification, but I don't necessarily think I was maybe just from a pure pay standpoint, paid differently for having 2 years of residency. But I don't think I would have gotten the job that I got right out the bat if I didn't have residency. So there is that standpoint. Like you might be going right into a staffing position without residency and then have to kind of go through things over time before you move into maybe some of those accelerated roles. But it also doesn't happen at every institution. So I can't say that that's like, going to happen everywhere. But I do think it's made me specifically a better leader, a better pharmacist, et cetera, going into those things. But I think we need to talk more about how is that reward or the ROI coming back and not just a monetary value.